Good afternoon, everybody, and thank you for attending today's webinar, Preventing Diabetic Foot Amputations. We're lucky enough to have Fiona Murray, a podiatrist with over 20 years experience from country SA, to discuss a diabetes foot screening program which she has brought over from the UK. My name is Sarah Raverstein and I'm from the Improvement Foundation, but I'm only doing the preliminaries today and we will basically be hearing from Fiona.
Okay, thank you, Sarah, and thank you very much for the opportunity to speak to you all today. I am talking about a foot screening program, but this in itself is not training to perform a foot screening. It's basically about the reasons why we need to think about having a statewide screening program. Next slide. So we all know that diabetes is becoming more and more of an issue. It's a bit of a tsunami. When I moved over from the UK in 2012, I had come from running one of the biggest diabetic foot services in the UK and looked at the amputation rates in Australia, and I have to say I was shocked. Next slide. This slide from my presentation that I was asked to do not long after I arrived here in 2012. And effectively, the Australian diabetes-related amputation rates are not very good in comparison to Europe and the UK, and in particular Scotland. So the estimate, and it was only an estimate in 2012, was that the diabetes-related amputation rate was 20 per 100,000 in South Australia. Next slide. What you can see from this slide, this has come from the Atlas of Variation, which was released, the first one was released by the federal government in 2015. And this is based on the actual 2012-13 data. And what it actually demonstrates, instead of the predicted 20 per 100,000 amputation rate in South Australia, it's actually 40. So it has more than doubled from the estimate. And that estimate had doubled from the previous 10 years. So in the last 20 years, the diabetes amputation rate has quadrupled in our state. Next slide. Now, there are variations across the state. So obviously, not unsurprisingly, the better results are in the metro areas. But that's still 17 per 100,000. And if you look at outback Australia, then that's where we're hitting the 40 per 100,000. There are places in the third world that have a better diabetes-related amputation rate than we do. So it's quite dramatic. Next slide, please. So this shows you the breakdown across the state of the amputation rate. And even though metro is 17, which is better than country, that's still 3 times what Scotland's amputation rate is. So it's still significant in global terms and significant for all of the wrong reasons. Next slide, please. So whilst I'm talking significantly about facts and figures, all of those amputations have a hidden cost to the client and to our population. So of those who have had an amputation, about half will experience a subsequent amputation of the other limb. The 5-year mortality rate varies from 30 to 80%, which is significant. And the amount of time that people are spending in hospital following their amputations is 26 days. And it is expensive. It is costing our health system just for the procedure and the hospital time a lot of money. That doesn't count the impact it has on the communities, on people losing jobs, not being able to provide for their families. So the impact of an amputation is absolutely massive. Next slide, please. These are the recommendations from the Atlas of Variation. So if you go into the Atlas of Variation, which is on the website, you can look at all of the data that I've put up, and it gives some recommendations for how to address what is a significant health issue for our state. These recommendations are not new. They have been around probably for 25 years. So in 1989, there was a meeting in St. Vincent's, and it brought together most of the people working across Europe who work in diabetes. And they put out a recommendation that they were going to reduce the diabetes amputation rate by 50%. And that was in 1989. We're now in 2016, and whilst Australia wasn't a signatory to that agreement, they have supported the goals of the St. Vincent Declaration. And we're not doing very well by any measure of health metrics. Next slide, please. So, are we asking the impossible in Australia? What makes us so much worse than the rest of the developed world? And it's not, we don't have the health services, we don't have enough doctors and nurses, because we know that that's not the case. Particularly in South Australia, we have more doctors and nurses per head of population than most other places. So there is something that is not happening that is happening in other places. Next slide, please. This is again a slide from 2012, and it's what is the difference. So in the time that our amputation rate has quadrupled, Scotland and Norway have managed to reduce theirs by 30% and 40% respectively. And this is how they've done it. And this is basically a well-coordinated, widespread primary diabetes screening program. So when I was working in the UK, we developed this system and we moved the responsibility for the primary diabetes screening out of podiatry and into primary care and across a whole raft of other disciplines. And we provided consistent training, a consistent score sheet, and we opened access to the public podiatry services to anybody who was screening could refer a client into us. So we reorganized as a profession, as a discipline, but we also reorganized the system, and it is the system that's the problem. So we know from audits that we have done that some clients will receive 2 and 3 diabetes foot screenings, whilst a significant proportion of other clients, no one's looking at their feet. And what we know is that the more that people have their feet looked at and are looking at their feet themselves, the more likely they are to prevent an amputation. So one of the really important factors with this is the risk stratification of clients, and for that to be done consistently. Next slide, please. So preventing amputations is not rocket science. It's really quite basic. So the work that I did was then taken by Scotland and developed into a nationwide screening program and risk stratification, and this is what you can see here. Now we have the opportunity, because this was based on work that I did, that Scotland have basically given it back to us, so we can use any of the materials that they've developed, we can use their system and hopefully take it forward. So next slide, please. So obviously, I'm just going to very quickly talk about what it is we need to assess. So I'm talking about the absolute basic foot screening, which is in all the literature, and that's really looking at neuropathy and peripheral vascular disease. And it's a 10-gram monofilament, and it's palpating pulses. So there are a lot of screening tools around that are significantly more complicated, that take more time, but this baseline screening, which is neuropathy and peripheral vascular disease, is what we are looking at needing to do. Next slide, please. So this is a short snapshot. This is just the current sites that you need to test for a monofilament. As I said, this is not teaching you how to do this screening program, but I am happy for people to contact me, and my contact details at the end of the presentation. I look after all of the podiatry teams across the state, so I can link you up with your local teams, and they can provide the hands-on training in the consistent manner in which we need to do this. So that's the monofilament sites, and if you next slide, please. And that's just one of the pulse points, which is just on the top of the foot. Next slide, please. And that's one behind the ankle. So it's really 3 clinical activities and some observations. So the longest part of performing the foot screening is actually getting the client to take the shoes and socks off, although here that's a bit easier because you don't get rugged up for winter in the same way that we do in the UK. Next slide, please. One of the things that we have that Scotland doesn't have is geography. So if South Australia is 4 times the size of the UK and Scotland is a tiny bit of the UK, we have some interesting challenges. So rolling out a statewide screening program across all of our communities, both metro, rural and remote, brings with it its own challenges. But I'm absolutely sure that we can find some innovative solutions because we've done it in other areas. And I'm particularly thinking of the cardiac network, ICCNet. Next slide, please. So in terms of being able to address the amputation rate across the state, we actually need to initiate a widespread skills-based training program to teach multiple staff how to do a proper primary diabetes screen that uses one screening tool that has consistent risk levels assigned to the clients, to develop a comprehensive database so that once that screen has been done, the information is held somewhere that people can access, as opposed to it's held within the podiatry notes, it's held within GP practice, it's held by the Aboriginal health worker. So we need somewhere that information is open to any healthcare provider that interacts with that diabetic client. We are working very hard in country to reconfigure the podiatry services so that we can provide targeted interventions, so that clients with the appropriate risk receive the appropriate care. So for those clients that are stable, low risk, that appropriate care is sitting in primary care with somebody who knows what they're doing, looking at their feet on a yearly basis. And then if they develop a problem, that's sending them into the public health system on a fast-track referral. So that problem, they're not sitting on a waiting list for 3 months while that problem gets worse. So this is all about developing the right systems. The other thing is adopting some ward programs. So because of the neuropathy, we find that a lot of clients that are in wards for a significant period are developing problems because there's a lack of awareness that they don't feel their feet. So there are some innovative programs. Feet First is one in Scotland at the moment called CPR, which is Check, Prevent, Record, which is looking at all new admissions that have diabetes. So there's a lot of things that we can use. New slide, please. So this is a screenshot. I've been working with Rosie Tiramaku from ICCNet to actually start piloting and actually playing around to set up an open, when I say open access, open to anybody who has the healthcare logon for this system, so that we can actually start to look at having a database that the information can be put onto, that multiple health providers can actually look at, so that we're not getting people falling through the gaps. Next slide, please. And they've taken the Scottish system and put whistles and bells on it. So we currently have the ability to upload photos. So if somebody's in one of our outreach sites, say Cougar PD, and they've got a problem foot, they can upload a photo. And then one of the clinical podiatrists that's associated with that area, they can go in and have a look at that photo. They don't have to be on site. So there's a lot that we can do using telehealth and actually addressing the challenges of our geography that will help us introduce this. Next slide, please. So I guess this is a bit of a call to arms. In the 4.5 years that I've been here, the amputation rate has doubled, and it's unacceptable that there are places in the third world that have better amputation rates than we do. Next slide, please. So I would have liked to have started this 4 years ago. We didn't, and I really don't want to wait another 4 years. Today is now, and this is when we need to start. We need to start organizing. We need to start coordinating our efforts to actually address this. Next slide, please. So that's the bulk of my presentation. As I said, it isn't a training program per se on foot screening, but I am happy through all of the country health podiatry teams to facilitate that training. But it's, I guess, a call to arms. We need to be addressing this, and the responsibility sits with all of us, not one particular profession, not one particular sector of healthcare, but it needs to be a collaborative effort. And if we do take this up, we know that it will work. In the 12 years that this has been run out across Scotland, they have reduced their amputation rate by over 30%. That is significant in terms of outcomes for our communities. So thank you for listening, and I'm happy to take any questions.
Great, thank you so much, Fiona. I do have a couple of questions that came up in the chat pane, so I will read them out. And if you, and Janine and Ryan, if you want to add anything to that, I'll just pop your hand up and I'll unmute you. So firstly, Janine asked, hi, in a GP clinic doing EPC program assessment, we do foot pulses and monofilament testing. If a patient's considered low risk, should they be referred for podiatry assessment yearly anyway, or only in any doubt, only if there's any doubts?
I would say only if there's any doubt. So that's one of the things that I come back to, and I didn't put a slide in about the risk stratification because it's based on the score sheet. But again, what we know from the international literature and the experience in the UK and Europe, if you give the client, a low-risk client, the right advice, which is basically check your feet every day, keep your skin in good condition, check your shoes before you put them on, and they're armed with that information, and they have their feet looked at once a year by somebody who knows what they're looking at, that will keep them safe. There was a paper published in the UK nearly 20 years ago that basically said the most cost-effective thing to address diabetic foot problems is for a doctor to ask the client to shake their shoes and socks off and look at their feet. It doesn't so much have an impact if I, as a podiatrist, or even, I'm sorry, nurses, but the more that we get people to, particularly the GPs, to acknowledge to the client that their feet are important and they need to be looking after them, that actually changes behaviour.
Wow. Okay, thank you for that. Did you want to add anything else to that, Janine? Okay, so we'll just keep going. So I also have a question from Ryan. Do you think patient compliance with the treatment regime is also a contributing factor?
Yes, I mean, it is with everything, but one of the things that we developed in the UK, diabetes education, there's loads of it around. And what we found that was, we'd say to them, check your feet. We didn't actually tell them what they were checking for. So when we replaced the check your feet with, if you see this, and had real life photos of, you know, the things that we would say would ring alarm bells, and we actually developed some based on a program called Desmond, which is Diabetes Education and Self-Management for Newly Diagnosed, and it's a skills-based education program. So we would invite clients in with their carers, with their families, and we would actually teach them to cut their own toenails and how to inspect their feet. And we would buy disposable nail care packs, and we would give them their nail care pack, which had a decent pair of nippers in. So when you actually give them the information in a way that they understand and very visually, and give them the skill set hands-on, then actually they can look after themselves. And it's that low-risk group that we really need to target, because currently all the metro services are all targeted at that top 5% that have already got the holes in their feet. And the biggest predictor of having more problems is having had a problem in the first place. So if we can stop that upstream, those people getting problems in the first place, or if they do develop a problem, they know what it is and they can know where to go and get help. That's what's going to make the difference. So yes, compliance is important, but it's giving them the information in a palatable way for them.
So Fiona, I had a question for you. You mentioned that there's lots and lots of resources out there, which is correct, but is there any information or any one place that you think is better than another for people to go and get their information?
I guess it depends what information you're talking about. So if it's
okay,
whether it's information for clients or whether it's information for clinicians, they're obviously different sites.
Okay, all right, great. And I just noticed, sorry Ryan, I didn't see this before. He just made a few more points. He said, few of my patients would actually choose to see a beautician and have their nails cut instead of seeing a podiatrist. And he's saying, I am thinking of ways on how to change this kind of mindset.
I guess, so they would choose to see a beautician, did he say?
Yeah, he said a few of his patients would rather see a beautician and have their nails cut there instead of at a podiatrist.
And then mine would be, don't change that mindset, educate the beautician.
Or start offering to paint their nails?
Well, you know, at the end of the day, what we know is it's the contact. And if that beautician knows what they're looking for and can actually go, oh, I'm uncomfortable with this, you need to go see them, then that's great. What it is, it's the more people looking at feet with the knowledge of what they're looking for that makes the difference. So we need to get over it. Either, you know, it's widespread. So I would love to train, you know, if beauticians wanted to come along, brilliant. I wouldn't necessarily have them do the primary screening, but certainly the visual inspection for those warning signs, yes, absolutely. Aboriginal health workers, aged care sites, personal carers, anybody, we can train and develop the skill set in anybody. It's what happens with that information when the alarm bells go that also makes a difference. And that's one of the things with the EPCs, is that the screening might be done as an EPC, but where does that information sit? If it sits primarily back with the GP, then it's siloed. So what we need, one of the core things, and I would like to start discussions again with the PHN, is we actually need a system-wide approach. So we need that online database where whoever's screening those feet can put that information in, and then it can trigger alarm bells to podiatry as the next level, or wherever that needs to go, so that we can actually use the information when it is collected. But if you have somebody that is low risk, that has normal nails, and all they want is that they can't get down to the nails because their belly's too big or whatever, then actually a beautician is appropriate. It's getting at the beautician to say, when you see this, that's when you need to pass them up. You know, if somebody with very high risk was accessing a beautician as opposed to podiatry, that's a different ball game. But it's the appropriate care for the appropriate risk level, and that's what we don't have. We don't have that really stratified levels of intervention.
Yeah, and Ryan's written exactly. Thank you, Fiona. So that's great. I have Janine as well. She says, is ICCNet assessment form widely available or something similar available to adapt to GP practice and then give a copy to patient?
We're working on that. So the ICCNet screens are based on a paper form that I developed. I've just been talking to the GPs in Kapunda and given them the score sheet, and they're going to look at putting that onto, I think their system is ZMed. So again, it's the fact that the score sheet and everything is the same. It doesn't matter which system it sits in. I mean, ideally, if you use the cardiac networks at IPOC, then it's on that basis in what we call the demilitarized zone. So it's not an SA Health specific database, but this is where, you know, we need to work with the PHN, with the GPs to actually look at how do we have that information shared across the system so that when somebody goes up a risk level, it's triggered to send them to the right place. And I don't have the answer.
Okay, I'll just check to see if there's any more. Great, would be very keen to get a copy onto our ZMed as well. So Janine, as Fiona mentioned, and as you can see on the screen, you've got her mobile, which she's kindly given us, as well as her email, and she's happy to take any questions or any information you'd like. Please feel free to email. So well, today's webinar is the last for 2016. So thank you so much for your attendance today and for this year. And thank you, Fiona, for presenting to us today. And it was really informative. It was fantastic. I hope you have got a lot out of today's webinar. I'd like to thank you for attending again, and on behalf of the Improvement Foundation, I wish you all a happy and safe holiday season. And please look out for our webinars, which will be starting in February next year. Thank you again, and yeah, have a lovely Christmas.